Okay, today I'll be talking about Tetralogy of Fallot. In Tetralogy of Fallot, there are four main components of congenital malformation in the heart. One way to remember is based on the acronym of PROOF. So I have pulmonary stenosis, right ventricular hypertrophy, overriding of the aorta, and VSD. So visually, how does the Tetralogy of Fallot looks like? Okay, this is a normal heart view, the four chambers heart view. Right side and left side. So in the right side, right atrium, right ventricle, left atrium, and right ventricle. So what happened in the Tetralogy of Fallot is that there is a stenosis at the infundibular part of the pulmonary. The stenosis can occur in the pulmonary artery itself, or it occur at the subvalvular part, where it is at the infundibulum. So stenosis here. So what happened when there is a stenosis in the right outlet outflow? So in the right ventricle, there will be higher pressure needed to pump out the deoxygenated blood from the right ventricle into the lungs. So when there is higher pressure needed here, there will be myocardium hypertrophy over the right ventricle. So this is the right ventricular hypertrophy. So when there is stenosis, hypertrophy. So and also at the same time, they will have a ventricular septal defect here, which cause so the overriding of aorta can occur exactly at the VSD, following the VSD. So these are mainly the four main components of Tetralogy of Fallot. Okay, for when there is a higher pressure needed to overcome the obstruction at the pulmonary infundibular, so here is higher pressure as compared to the systemic on the pressure on the left ventricle. So blood flow will the deoxygenated blood will flow to the right atrium into the right ventricle, and because of the higher pressure here, it will cause a shunt to the left ventricle. So the deoxygenated blood and also the oxygenated blood from the right ventricle will mix here because of presence of the PSD, and the mixed blood will flow out of the aorta to the systemic circulation. So this is the this gives rise to the cyanotic appearance of the patient. So what determines the level, the severity of the cyanosis is based on the degree of stenosis at infundibular. So the higher the stenosis means the higher the pressure, means more blood will be shunt to the left side. So patients with Tetralogy of Fallot will experience TET spell or hypercyanotic spell, where they will become more cyanosed when they, for example, feeding or doing exercise, strenuous exercise. So how do they reverse this cyanosis by themselves is by squatting down. So what happened when they squat down is that they cause a kinking of the femoral artery, which increase the pressure in the systemic circulation that will eventually overcome the high pressure in the right ventricle and will reverse the shunt, the left to right shunt, and that is how the cyanosis is reversed. So Tetralogy of Fallot is also associated with genetic syndrome such as trisomy 13, 18, and 21, and also DiGeorge syndrome, charge or factorial association, Alagille and Holt-Oram syndrome. And Tetralogy of Fallot is the most common cyanotic heart disease in live birth. What is the management of Tetralogy of Fallot? We can divide into pharmacological and non-pharmacological. For the non-pharmacological treatment, you can help to increase the preload by doing a knee to chest position, same like we ask the patient to squat or to do a Valsalva maneuver, or others we can the pharmacological treatment is by increasing the preload by giving fluid boluses, or to decrease the catecholamine production, which is by giving IV morphine, and to decrease the heart rate, usually we start beta blocker. So the surgical treatment in Tetralogy of Fallot is by first we can do a VSD patch to close the VSD, and at the same time perform a dilatation of the pulmonary stenosis.